Neurogenic Bladder Dysfunction, an overview by AZLAN ADNAN, 29th of July 2025. Neurogenic bladder dysfunction refers to a condition in which the normal nerve signals between the bladder, spinal cord, and brain are disrupted, leading to problems in bladder control. This dysfunction may manifest as either an overactive bladder, which contracts too frequently or involuntarily, or an underactive bladder, which fails to contract adequately to allow proper emptying. The disorder may be congenital, such as in spina bifida, or acquired through spinal cord injuries, multiple sclerosis, Parkinson's disease, stroke, or diabetes mellitus. The condition is not a disease in itself, but a result of neurological impairment that affects bladder storage or voiding. As such, the clinical presentation varies depending on the nature and extent of nerve damage. In all forms, neurogenic bladder significantly reduces quality of life and may increase the risk of urinary tract infections, bladder stones, kidney damage, and incontinence. Signs and symptoms. Patients with neurogenic bladder may present with a wide array of symptoms, depending on whether the bladder is overactive, underactive, or exhibits dyssynergia, lack of coordination between bladder and sphincter muscles. Common symptoms include urinary incontinence, both urge and overflow types, increased urinary frequency, including nocturia, urinary urgency and inability to delay urination, difficulty initiating urination, incomplete bladder emptying or retention, recurrent urinary tract infections, bladder distension or discomfort, loss of bladder sensation in some cases. In severe cases, complications such as hydronephrosis and renal failure may result from back pressure on the kidneys caused by poor bladder drainage. Pathophysiology. The micturition reflex, the act of urinating, is regulated by a complex neural network involving the cerebral cortex, brainstem, spinal cord, and peripheral nerves. When this neural circuitry is impaired, communication between the bladder and the brain becomes dysfunctional. Upper motor neuron lesions, as seen in spinal cord injuries above the sacral level, typically cause detrusor hyperreflexia, frequent and involuntary bladder contractions. In such cases, the sphincter may contract simultaneously, a condition termed detrusor sphincter dyssynergia. Lower motor neuron lesions, affecting the sacral spinal cord or peripheral nerves, often due to diabetes, result in a hypotonic or areflexic bladder that does not contract effectively. This leads to overflow incontinence and high residual volumes. Neurogenic bladder dysfunction is a well-established manifestation of diabetic neuropathy, a condition rooted in insulin resistance of the nerves. The pathogenesis involves the accumulation of ectopic fat, which interferes with insulin signaling. Specifically, this fat deposits around nerve cells and obstructs insulin receptor sites on their surfaces. As a result, insulin is unable to bind effectively to its receptors, preventing glucose from entering the nerve cells. Starved of their primary fuel source, these neurons become energy deprived, leading to progressive atrophy and eventual cell death. In the context of the bladder, this degeneration of peripheral autonomic nerves contributes directly to the disruption of micturition reflexes and detrusor muscle control. Chronic retention causes bladder wall hypertrophy, fibrosis, and loss of compliance, further worsening the dysfunction. Moreover, the cascade of infection, back pressure, and renal compromise may follow if the condition is left untreated. Medical treatment. Medical management aims to preserve renal function, prevent complications, and improve quality of life. Treatment strategies vary based on whether the bladder is overactive, underactive, or exhibits dyssynergia. Anticholinergic drugs, such as oxybutynin or tolterodine, are prescribed to manage detrusor overactivity. For patients unable to empty their bladder adequately, intermittent catheterization remains the gold standard. Where this is impractical, indwelling catheters or suprapubic catheters may be used, though these carry higher risks of infection and stone formation. In cases of detrusor sphincter dyssynergia, alpha blockers such as tamsulosin may help relax the urethral sphincter. Botulinum toxin injections into the bladder or sphincter have been used effectively in refractory cases. For select patients, surgical interventions such as bladder augmentation, urinary diversion, or implantation of sacral nerve stimulators may be indicated. Regular urodynamic testing and renal function monitoring are essential in long-term management. Alternative treatments. While conventional therapies remain the mainstay, a number of alternative approaches are increasingly sought by patients aiming for a holistic, adjunctive approach. These therapies do not replace medical intervention, but may help alleviate symptoms or enhance general well-being. One such therapy is manual lymphatic drainage massage, which promotes circulation and detoxification. Though not directly treating the neurological cause of bladder dysfunction, it may relieve pelvic congestion, reduce inflammation, and improve peripheral circulation, particularly in patients with concurrent edema or reduced mobility. Another increasingly popular complementary therapy is Ayurvedic hot herbal oil lymphatic drainage massage, known in Sanskrit as abhyanga, combined with svedana, herbal steam. Warm, medicated oils are applied and massaged rhythmically across the body, particularly the lower abdomen, flanks, and sacral area. According to Ayurvedic principles, this approach helps restore vata balance, which governs nerve function and elimination. The oils, often infused with ashwagandha, dashamula or bala, are said to nourish nerve endings, soften connective tissue, and stimulate lymphatic flow. Lymphatic drainage massage works by stimulating the lymphatic system to remove metabolic waste, including ectopic fat. This ectopic fat, as discussed, contributes to insulin resistance at the neuronal level by physically blocking insulin receptors on the nerve cell membrane. The herbal oils used in Ayurvedic massage are believed to contain natural emulsifiers, which enhance the breakdown and excretion of this fat. By removing the ectopic fat, insulin signaling is restored, glucose uptake by neurons improves, and nerve function begins to recover. This reversal of insulin resistance at the cellular level may, in turn, lead to the alleviation or even elimination of neurogenic bladder symptoms in select cases, particularly those of metabolic origin. While scientific validation for Ayurvedic massage in neurogenic bladder remains limited, anecdotal evidence suggests benefits in relaxation, stress reduction, and improved autonomic regulation. Stress is a known aggravating factor in bladder dysfunction, and interventions that modulate the autonomic nervous system may indirectly benefit symptoms. It is important to stress that these therapies should only be undertaken under guidance from qualified practitioners and in consultation with the patient's neurologist or urologist to ensure safety and avoid contraindications, especially when indwelling devices or infections are present. Conclusion: neurogenic bladder dysfunction, though complex and variable in its presentation, is a treatable condition with a multidisciplinary approach. Modern urology provides effective tools to manage both storage and voiding disorders, preserve renal health, and prevent complications. At the same time, integrative practices such as lymphatic drainage massage or Ayurvedic therapies can offer supportive benefits, particularly in symptom relief and enhancing quality of life. The most effective care arises from personalized treatment plans that recognize the interplay between neurological, urological, and metabolic dimensions of the disorder.